I'm excited to be here today with you guys. I'm going to be talking a little bit on trauma-informed care approaches to foster care, which is a really broad topic. Tried to condense and hit some highlight points for you guys for the next 15 to 20 minutes. So bear with me. We'll get started. Sorry, guys. There we go. So I have no financial disclosures. So today we're going to talk a little bit about identifying symptoms of trauma and the impacts of the health on the child. We're going to describe some key ingredients and principles of trauma-informed care approach. Talk a little bit about how we can apply it in primary care practice and provide some resources for primary care providers. So I thought we'd start with just a poll and seeing how many of you are already incorporating a trauma-informed care approach in your practice. So I'm going to have Shoshana put the poll up, and you should see it pop on your screen in a little bit, get you guys to answer.
You should be able to see it now.
So Shoshana, I'll let you know when everybody, I feel like we've had enough time and you're seeing the responses.
Yeah, we're still seeing some responses come in. We'll give it at least 10 more seconds here.
So we're going to find out if this is just a review for everyone, or there's some more stuff for everyone to learn, I think, a little bit to see kind of what you're doing in your practices right now.
Okay, I'll be closing it in 5 seconds. I'm sharing the results.
Okay. So what I'm seeing is there's about 76% of us that are already using it in our practice, and about 24% are not. So for some of you, this is going to be a review, and the rest, we hope that you have some take-home points that you'll take with you into your practice. Okay. So when I did probably one of the first kind of talks I did several years ago about a trauma-informed approach, especially with kids in foster care, I thought about kind of trauma and kind of what it means and what does it mean to other people, and thought I'd just see kind of in my own practice what everybody thought when you asked them what do they think when you hear the word trauma. So a non-scientific survey I did in our practice, our nurses said stabbing wound, head wound. We had some of the pediatric residents said checking the ABCs. And one of the pediatric attending physicians said a small child cutting his foot on his glass. So the majority of the responses were related to some type of physical injury or something related to the physical body, and not really anything related kind of to the emotional behavioral well-being. So I think that was a good starting point of kind of in my own practice of seeing kind of what they thought of when they thought of trauma. I think it's really neat to see when I did this talk several years ago to compare now. I'll talk a little bit later about kind of the changes and the shift that we've made in our practice here at MUSC. So when we talk about trauma, I think it's really important that we're all talking kind of about the same thing. And so the SAMHSA, the Substance Abuse and Mental Health Services Administration, gives a pretty much global kind of as far as definition for trauma and what we're going to be talking about today in the context. And it's basically exposure to traumatic events or situations, and they basically overwhelm your ability to cope as an individual. And they affect your mental, physical, socio-emotional, spiritual well-being. So we're talking about child abuse, maltreatment, neglect. We're talking about a family member with a mental health or substance use disorder. We're talking about the loss of a loved one and grief, experienced or witnessing violence, poverty, and systemic discrimination. These are just a couple examples. And when we talk about trauma, we talk about in the 3 E's of trauma. So the actual event, the circumstance that caused the actual physical or psychological harm, the experience, which can be different for each individual. So how I experience today compared to somebody else, an event that experienced the same exact events, we could have different kind of experiences and responses. And then the effects, which I think is a really critical component of the trauma. It can be short-term and long-term. It could be range from hypervigilance, like that flight or flight response, or it could be kind of a numbing avoidance, where it eventually wears down both physically, mentally, and emotionally. So what do we know about complex trauma and toxic stress? not necessarily good, but we do know that it's actually pretty common. About 2/3 of children report a traumatic event by age 16, whether it be a motor vehicle accident, a loss of loved someone, child maltreatment, any of the several things that we've talked about. It's actually pretty common. And what we know is that the more trauma that we have, the worse off it tends to be, and long-term effects that can affect our psychiatric, medical problems, high-risk sexual behavior, high-risk behavior in general, socioeconomic factors. And we know, like we talked about before, is that kids respond to trauma and toxic stress in different ways. Clearly, more is bad. And the American Academy of Pediatrics recommends that we screen for traumatic stress and other childhood adverse events. So why should we be trauma informed? So most of us are pretty familiar with the ACEs study. I mean, so there's data to show that adverse child events, if not addressed, can result in not good outcomes. We know that trauma is not good, and like we talked about, the more trauma there is, the more worse off you can be. But also trauma can look like a lot of things that we treat as primary care providers. So it's important that we are trauma informed so that we know what we're treating. So if we're treating something that we think is ADHD that really could be trauma, you're not really going to see improvement until you get to the core of what the problem is and provide that treatment. So trauma can look like ADHD, ODD, depression, anxiety, complex grief, bipolar, separation anxiety. And what we know is that trauma, there's treatments that exist for it, evidence-based treatments that do work. And so identifying it and getting kids into treatment is going to end up in better outcomes so that we have better results for kids, both in their behavior, development, their physical health, their relationships, and their education. So when we think of trauma and we look at kids in foster care, I like this graphic because I feel like a lot of times what we see for our kids, up on the top, everything looks okay. But as you, like an onion that you peel back those layers or that potato, you look up underneath and there's lots more underneath that needs to be addressed and worked through. So when we think about our approach to trauma-informed care, it can't be just, I think for us, it's really important as we do this talk, we can be that kind of agent of that begin to be change in our practice if we're not already providing trauma, or improve the care that we're already providing. But we need both organizational and clinical. So us as providers, screening and assessing for trauma, but also looking to our leadership, engaging our patients, all our staff, from the registration staff that's at the front desk where they meet the kids, to our janitorial staff, to our nurses, to our providers. They're all there as a part of the team to provide this trauma-informed care approach. So one, we have to realize that trauma exists and that there are long-term effects and that we need to recognize to make a difference and change. We need to be able to recognize the signs of trauma and knowing what they are. And then not only recognize them, but we also need to be able to respond to them to get these kids the support that they need, and the families as well. And I think as healthcare providers, we're very guilty of this, is we need to resist re-traumatization. So we want those vital signs. We want to give those vaccines on that schedule on that exact day. And realizing that for some of these kids, they've been through a lot of rough stuff. And so prioritizing what needs to happen and doing it in a trauma-informed approach. We're not restraining kids and holding kids down all the time just to get something that we need and check something off the box. And so there's got to be that shift in that culture from what's wrong with you to what happened to you. And I definitely can say that I feel like in our practice, we've seen that shift in that culture. And I'd love to hear from you guys at the end to see kind of what you're seeing in your practice as you move to a more trauma-informed care approach. So some components that are important is safety. So I think thinking of safety from the time that your patients arrive at your facility. You know, some patients are there early in the morning, some are late at night, making sure that it's well lit, exits are clearly identified, that they feel comfortable and safe in the environment, that we're being trustworthy and transparent. We're letting them know what's going on. We're empowering them and letting them have a voice and collaborate in their practice, because I can make recommendations until I'm blue in the face, but if I don't have my patient on board and they don't have buy-in and are willing to do it, it's not going to help them and be a part of the process. And then making sure that we're taking into account cultural, historical, and gender issues as you're looking at your policies and your protocols. So there's a lot on this slide. I think the thing is like we've talked before in previous slides, you have to have kind of from the top down from leadership as far as to make change and to shift the culture in your clinic. But I think I don't want to get bogged down in that, because I think something simple is what I've learned is with me and my colleagues at MUSC is that being the agent and taking that back and taking that step and making the change can make huge difference and lead to those leadership and organizational changes. But I think it's important to remember that you're looking at policy and protocols, you're making sure you're having some quality assurance, that you're evaluating, that you're considering as far as finances and things that are needed in order to make your clinic more trauma informed in their approach. So putting into practice, like I said, when I did the survey years ago, everybody kind of came up with physical, and that emotional, psychological well-being of the patient kind of really wasn't in the picture. And definitely seen a shift in the practice, just like we talked about in that first session for those that were able to join in with Gwen Goodlett. We've shifted to where we do our first, like our comprehensive assessments for children in foster care in a 2-part visit. So we're not poking and prodding them. If I have to do vaccines and I need to do blood work, I'm talking to the families and talking to the kids and helping them to choose. You know, I push for those vaccines a lot of times for that first visit, but maybe we wait and do the blood work that next visit. Seeing families, the nurses, the shift in our, they used to, you know, would kind of hold the patients down, I feel like, at kind of any cost to get the blood pressure, those, you know, the temperature, all those things, coming back to me and saying like, hey, I was able to get a temperature, I was able to get, you know, X, Y, or Z, but I couldn't get the blood pressure. You know, I really don't think that this is in the kid's best interest right now to do it. I can try later if you feel like you need it. But being able to see the nurses take the initiative and see like, hey, this isn't the kid's best interest right now. Let's get him what he needs today, and maybe we'll try again later, or we'll try again next visit. Seeing our residents and our attending physicians in our practice as well, just in considering including in their differential trauma. We had the pleasure of Dr. Wallace, our director of the foster care clinic, as well as Rochelle Hanson with the Crime Victim Center, developing a couple of questions to add to the pediatric symptom checklist that are trauma, looking at assessing for trauma, having case managers now in our clinic to help as far as get the kids where they need as far as for the treatment when trauma has been identified as the problem, as well as having therapists in our clinics. So I think those big things of just getting a change and a shift as traumas as in your differential as a possibility of kind of what's going on and leading to some of the presenting problems with the children. Open-ended questions, I think it's been really cool to see, especially with our residents in our clinic, to be okay with silence, that awkward silence that's so uncomfortable sometimes, but willing to just sit and wait and allow families to talk when they're ready and kids to talk when they're ready. Using direct questions when needing, but using general open-ended questions and just letting families talk at their own pace and when they're ready. I think also realizing that sometimes, you know, as providers, we have agendas. We need to do a well check, or we need to do X, Y, and Z. Really, that might not be what that family needs that visit. And what they need is to discuss what's kind of heavy on their heart, or what's going on in their family right then, or the presenting issues, and being willing to kind of, you know, table the other stuff, but deal with the question at hand. Being empathetic and providing education. I think that's key. I think I have a lot of seasoned foster parents, which I know, I'm sure of you probably have in your practice as well. But still, just every kid is different and every trauma is different in what they experience and how they experience, and realizing that and being able to support them and provide the education, as well as it can be a lot, even for some of my seasoned foster parents, some of the horrific trauma and neglect that these children have been through. So being there to support them. I think one of the things that we talked about in the first session is seeing these kids more often, because we know that they have increased risk for health problems, mental health problems, educational issues. So we're seeing them often. So we're able to monitor, we're able to encourage them, we're able to meet their needs and kind of help them and guide them along. We talk a lot about common behavior problems in foster care. I like to say the things that kids control are typical behaviors that we see. So what goes in, what they eat, what comes out, what they pee or poop. A lot of times we see problems with just being, you know, talking about them for our kids that have had, you know, horrible malnutrition or neglect. Talking about having free foods around so that they don't have to hoard their foods, and they're not, you know, gorging themselves at meals, talk about the emergency packets that we talk about for families that they have at their bedside for the kids that like to get up and roam because they're looking at food. So knowing what those common behaviors are that present for children in foster care, and kind of providing education for families to help them support that. I think, again, don't push for the information, being okay with an awkward silence. And then we spend a lot of times talking with the kids, and encouraging them to families to talk with their therapists about kind of correcting those distortions that we see, and that a lot of times, you know, it's not your fault that adults unfortunately don't make the best decisions, and bad things happen, and it's not your fault, and being able to reassure and make those kids and families feel safe and secure. There's a lot that we can also do in our office, as far as teaching to take deep breaths, belly breathing, relaxing kind of those muscles, lots of things that we can do as we wait for them to get in to see their therapist and get the treatment that they need. And then the last is kind of praise those positive behaviors. I feel like a lot of my kids that I see, unfortunately, because of bad things that have happened to them, have a lot of what we call naughty behaviors. And so we spend a lot of times, unfortunately, talking about those naughty behaviors because that's why they present to clinic a lot of times. I try and find, at least with a family, have them talk about what's going really well for the kid, finding that positive praise. And if they can't come up with something, then I come up with something that I see that the kid's doing well, because we just, a lot of times we can get bogged down in kind of all the things that aren't going right and trying to make sure that we're identifying those things that are going right. And so shift in culture, I think that's kind of the biggest thing that I've seen when we talked about the PSC 17, having case managers in our clinic, having therapists co-embedded in our clinic, has been a very positive. But I think there's just simple change as far as, like I said, the nurse that's coming to you and saying, you know, hey, I'm not going to hold this kid down today. I'm not going to, you know, I know you probably need this, but I don't think it's the kid's best interest. Or it's the nurse that called because a resident in the clinic, you know, the kid didn't have a shot record and said, well, we'll just start from square one. And the nurse said, nope, we're not going to do that. That's not how we do it. You got to give me a second to try and get those records. This kid's been through so much. I feel like it made my heart just kind of beam with pride. I think seeing the shift and being able to recognize that sometimes kind of to check off a box on our list to get something done or get a vaccine or get those things is sometimes not in the best interest of the kid at that moment, and give us a time, because we're going to see these kids closely and we're going to coordinate with DSS to make sure that they get what they need, especially now that we have the nurses in place to make sure, you know, hey, we weren't able to get X, Y, or Z at this visit. You know, they're not going to be seeing us, but I need you to track down their next provider and make sure that they get this or that. Seeing that shift in the culture, I think it's been really cool to see, and I can speak probably for my colleagues from where we were to where we are now. We still have leaps and bounds to go forward, but it's exciting, and it is possible. And I just hit something. Here are some resources, some of the same ones that we provided. They're great if you haven't had a chance to look at. For providers as well as foster parents, the SAMHSA website, all of these are great resources. Questions? I'm going to turn it back over to you, Cheryl.